Hello and welcome to this video. My name's Kris, I'm an Australian GP, and today I'm going to be talking to you about hormones, more specifically about Polycystic Ovarian Syndrome, also known as Pcos. Did you know that you have over 50 different hormones in your body that play an intricate role in keeping you healthy and functional and able to do your day-to-day things? Did you also know that there's three main types of hormones? Those made from amino acids, those made from peptides, and those made from lipids. It's actually a really confusing part of medicine, and there are specialists that specialize in hormones called endocrinologists. So it's certainly not a simple thing to understand, but I'm going to do my best to break it down for you. In medicine, we don't talk about hormones having an imbalance when there's an issue. Instead, we talk about hormones being either too high or too low due to either an over or underactivity of either the area that the hormone is produced or in the cascade surrounding the hormones. Sometimes a hormone that's too high or too low is due to an organ's inability to continue to regulate hormone production. For example, the thyroid might not be able to regulate the production of thyroxine. Therefore, you may have too high or too low thyroid function, known as hyper or hypothyroidism. Hormone issues may also be caused due to exogenous or outside the body issues. For example, if you're taking steroids, you may impact your adrenal gland's ability to produce cortisol, increasing it and causing something known as Cushing's syndrome. Pcos is a diagnosis that I see so often as a general practitioner, both made by other GPs or endocrinologists or even gynecologists, but also those who have either diagnosed themselves or had their diagnosis made by alternative health practitioners. Quite commonly, these people believe that they have an imbalance in something. And as I've kind of already mentioned, that's not quite the case. And words are really important in medicine because words can bring with them stigma, shame, or a feeling of understanding when truly you might be on the wrong path. In Pcos, Polycystic Ovarian Syndrome, or PCOS, honestly, the most important letter to me is the S, the fact that this is a syndrome. Syndromes are groups of signs or symptoms that come together to characterize a particular condition. This is important because it means that there's not one particular test that can diagnose it, nor is there a simple way to treat it. In PCOS, there is something known as the Rotterdam Criteria, which allows us to diagnose PCOS or Pcos. To make the diagnosis, a patient must meet two of the three criteria. I will go into depth in these, but number one is having polycystic ovaries on ultrasound. Number two is having clinical or biochemical hyperandrogenism, which is having too high androgens like testosterone. So that it can be biochemical, like I said, measured in lab, or clinical, so signs or symptoms of it. So for example, acne, hirsutism, or having too much hair, etc. Again, I'll go into detail soon. And finally, number three, having oligo or amenorrhea, that is irregular cycles or not having a menstrual cycle to begin with. So let's start with the ultrasound. And having multiple cysts on your ovaries does not a diagnosis of Pcos make. In fact, one ovary that's a healthy ovary without Pcos can have up to 20 follicles before we even blink an eye at it. And sometimes you can have several follicles, say 20 or so, and it's still not concerning because it's not just the number we look at, it's also the morphology of the actual ovary itself and where the cysts are. Because we naturally create cysts, that's kind of how we ovulate, and if you're interested in me explaining that, I'm happy to. But if you had a normal number of cysts on your ovaries, but they were all peripherally lined up like a string of pearls, that in itself is actually more diagnostic, or at least would be a positive for the Rotterdam Criteria. And you don't necessarily have lots of cysts. Again, you may even only have a handful of cysts, but they would be very large cysts, in which case that also fits the Rotterdam Criteria. Sometimes we don't even look for cysts, it's size of ovaries. So what I'm trying to get at is that you don't have to have multiple cysts to have polycystic ovarian syndrome. It's also worth noting that someone may have polycystic ovaries without this syndrome. So if you have multiple cysts on your ovaries, but you don't have hyperandrogenism, either measured biochemically or symptoms, that is high testosterone, and or you don't have a lack of periods, either lack of regular periods or lack of periods, period, then you've got what we call PCO, or polycystic ovaries, not polycystic ovarian syndrome. So there is a definitive difference there. If you would like a video on that difference, I'm happy to do it. You just gotta let me know. So the next criteria 2, is the one that has to do with hormones. And this is the androgens, which I've alluded to are more the testosterones. Whether you're born female or born male, every human has testosterone or androgens in their system, and they are vital for function, not only reproductive function, but also metabolic rate, body habitus maintenance, insulin sensitivity, and even bone density and bone health. When we talk about clinical diagnosis or biochemical diagnosis, what I often see is people getting things like cheek swabs or spit tests that show that they've got high testosterone. My issue there is, unless it's ordered by an accredited physician and sent to an accredited lab, you cannot guarantee those results are true. This is not to slag off or talk down to anyone who is an alternative health practitioner, because I understand all you're trying to do is help patients, right? But I am trying to say is that unless you have things done in an accredited manner, your diagnosis is not yet distinct. That being said, you don't need to have a blood test to diagnose PCOS. However, it is recommended. And if you are going to have a blood test, it should be done by someone accredited, sent to an accredited lab, and then compared to accredited values. Hormone levels vary from minute to minute, hour to hour, day to day, week to week. It all depends. And in a person who was born female with female physiology, we have cycles, and at different parts of our cycle, different hormones are higher. So it is really important to put everything in context, and this is why doing it at an accredited lab is super important. To break it down, polycystic ovarian syndrome occurs when there is a miscommunication between the pituitary gland in the brain and the ovaries, which are in the pelvis. You'll have a high luteinizing hormone, a low follicular stimulating hormone. This then results in a higher testosterone production, which can then decrease insulin sensitivity. It's really complicated. It's also really important to note that it is impossible to diagnose a person who was born female who is on the oral contraceptive pill with polycystic ovarian syndrome. This is because the hormones the synthetic hormones in the contraceptive pill will impact the hormonal axis, which then impacts how we measure your hormone levels. When you stop the pill, obviously all of that goes back to normal, but it can take a couple of months. So the guidelines do suggest waiting at least 3 months before having your hormones tested if you were on the contraceptive pill. Now, just remember that the pill is actually prescribed to help people with PCOS and their symptoms. So it's not all bad. I'm just trying to make a point that if you're going to diagnose, you shouldn't be on treatment or on the contraceptive pill if it wasn't for treatment of PCOS. You know what I'm saying, right? And the final criteria is having no or irregular periods. And a note on regularity. Yes, textbook-wise, every person with a uterus should have, once they hit puberty, a 28-day cycle that lasts about 5 days, blah, blah, blah. Almost no one is textbook. What is normal to you may be very different to what's normal to me or my parents or whomever. So, let's get one thing straight. Regularity means how frequently it occurs, not how far apart it occurs. So you may be you may have a 25-day cycle, and if it occurs every 25 days, that's considered regular. You may have a 40-day cycle, and if it happens every 40 days, that's considered regular. We are not clocks, so things are not going to be snappy, right? So you may have let's say a 28-day cycle. Let's say you're textbook. But then in 1 month you might come on day 27, the next month you may come on day 31, and that's still relatively normal. In fact, it is normal. So regularity, there is a bit of a, leeway there. But if you are having cycles that come on day 21, then the next time day 40, then the next time day 32, then the next day 39, then day 29, that's irregular, and that's what we call oligomenorrhea. Now, it's not in the Rotterdam Criteria, but to make a diagnosis of Pcos, we medical practitioners also have to ensure that there is no other reason for you to be having these symptoms. For example, if you are at a significant energy deficit, you may have hypothalamic hypogonadism. That took me so many tries to say, I'm so sorry. Anyway, having a hypothalamic hypogonadism can cause amenorrhea. That is, you don't eat enough, you don't get a period. It's a little bit more complicated than that, and again, that's a whole topic on its own, but that's an example. If you have a lesion on your pituitary gland, which is that little one in the brain, that can also change your hormonal axis and cause you not to have a regular cycle and may give you signs of PCOS. But if you've got a lesion on your brain, it's not the PCOS, It's a lesion on the brain. As you can see, Pcos isn't necessarily an easy diagnosis to make, and it's not an imbalance of hormones. It's a really complex interplay of hormones, yes, and their impacts on other things such as cysts on the ovary, acne, hair, weight changes, insulin sensitivity, but it's not simple. Now, I'm not going to talk about management or anything like that in this video, but if you're interested, please let me know. I just really wanted to break down what PCOS actually is and how we diagnose it and why we do what we do. So if you've enjoyed this video, please thumbs up, like it, subscribe, comment, leave me a notice as to what you want from me next, all that YouTube stuff. And until next time, guys, stay safe, stay healthy, and I'll see you in a video very soon. Bye.